Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com, your favorite orthodontist and craniofacial orthopedist here to talk about another Myo video and OMT, Anterior Openbite video. Let's talk about those cases. And I know you've had one, I've had many, where it's usually a female, but sometimes it's a male. They come in, they're maybe 20, 30, 40. Hey, I know I have an anterior open bite. I know I have a tongue thrust. I know I need a frenectomy. I know I mouth breathe, whatever. Fill in your favorite causation. Everybody's got something, but they're aware, right? Maybe they've seen a myo, maybe they haven't, maybe they're just super aware. They know that they're going to need a lot of work. They know it might be a jaw surgery case. They know that they might need myo. They just want flipping straight teeth. They want to know if there's a way you can give them straight teeth and not mess with their bite. Sometimes yes, sometimes no is my answer. So I like to say the devil you know is better than the devil you don't. So I would really prefer they go to the myologist first, get an actual report, get a release saying, yes, myo is recommended. But maybe you could start and not try to address the bite and they could do it later. I'd like to get something like that. If it's something super severe, no, you can't do it. So let's go over something where it might work and might not. And I kind of just picked two random examples. These are just from stock images. These are not patients I know. But, sometimes you just have to take a look at a patient, just flash and be like, maybe, don't ever say yes. And I would never, ever attempt in these cases, if you don't know your devil, you do not attempt to close the AOB. No, sorry. I normally, for adult cases, I say you go to myo first, you get the assessment. Sometimes myo will do the exercises first. Sometimes myo will they'll do a little bit and then they'll start you. Sometimes it goes the other way around. It really just depends. I have a lot of content already on this. I'm not going to go back to what I do, what I think. There's definitely some mistakes I've made, so look into my content. And I think a lot of this depends on how they're paying for it, whether fee for service, whether they're not, whether insurance is involved. That changes everything. So go back into all of that. I'm going to specifically talk about case A and case B here, and whether I can give them a compromised result with being within standard of care, not hurting the patient, not hurting my liability either. I'm not going to tell you how to write that document because that is a messy informed consent that you might even want to get your liability insurance involved in. Yes, people use chat to make it. I'm not a lawyer, so I'm not drafting this stuff for you. I'm just telling you my thoughts. If there's a way that I can straighten their teeth, so like what's going to happen, you have to understand the basic physics of what's going to happen if you just tossed. So I wouldn't want to do this in braces, for example, because there's no way I could control that in braces. That's going to be a nightmare to try to control that. But in Invisalign or ClearCorrect or something, I could do that. I could say straighten the teeth, but do so without extruding, 6, 7. I mean, obviously I'm after extrude 11 or upper left 3, but I don't want to extrude. In the process of extruding this, I don't want to extrude these, is what I'm going to say. At no point am I going to actively try to extrude these. Now, as we bring something down, these tend to go up. That's how physics works, right? So this comes down, you might get a POB in the back, you might get an AOB in the front. That's what's basically going to happen. So then what's going to happen? We're probably going to finish with about a millimeter and a half AOB. However, again, the devil you know is better than the devil you don't know. We don't know what caused this. If I had to guess, it could either be a thumb that goes in on the side at night, or it's a tongue that goes out at night, or a pen or a pencil or a nail. Now, nail biting aggressively will cause this. And no, you can't necessarily fix it with braces if they're done growing. So as you might create a crazy posterior or anterior open bite, you'd have to put that all in the terms. They cannot be upset about it if you finish like that. Now, obviously, the anterior open bite, they realize they're going to have a 1 millimeter one. That's their choice. If they don't like it, they can go get some restorative done later. This is not going to be included. So you have to literally predict what might happen. And without your devil paperwork from your myologist, you don't know. So you better write a very airtight informed consent and I certainly would never do it if it's an insurance case, because that's going to go back, and I've learned not to do anything compromised as insurance. It's got to be cash. And you better have a very good consent. And you better be checking in with them every single time. And I think anytime they decide they want to pull the ripcord, expect that you may have to give a partial refund or something. So just be prepared. You may not make money on these cases. These may blow up in your face later, because the reality is that you know more about what's going to happen if you finish them with an AOB. What's going to happen? They might have speech issues. They might not be able to bite into the sandwich, and the lettuce stays in the sandwich. They may say that's okay because I think it's a straight smile to start, but then when the reality actually happens, and then they're mad and they ask you to fix it, and they go to another doctor who says that you butchered them, this could still become a board complaint or something like that. So I'm trying not to freak you out, but I'm trying to explain what the risks are. Also, keep in mind, we never want to finish them in a more dangerous occlusion when they started. So here they've got anterior wear. So in some ways that might be better. Now I'd rather add some lower IPR or and tuck the lower teeth under too. But, it just depends on what they want to do. Now, in this case B, I ain't doing that. There's no way to do that. I mean, if this patient had like massive overjet, maybe, and when we took a look at the Ceph, the maxilla had a good enough airway. I mean, I know you can't assess airway from that, but you know what I mean. We're looking, in the CBCT, the 3D, at least a baseline airway. Obviously, I would do a sleep evaluation. I would do a mile evaluation. I would even love to do a sleep test. I would love to do that all. Are you going to convince a patient to do that all before they start ortho? Probably not. They're going to get mad and walk away. But I would try to get as much data as I could. I wouldn't want to make them worse, that's for sure. I wouldn't want to mess up their speech. I just think that there's no way I can do something improvement on this top without just jacking something up. So no, I wouldn't feel comfortable with this case because I know that's just going to be bad. But like I said, if we found out, let's say there probably is one hypothetical situation, assuming this is a little class, let's say this was class 2. I can't tell what the angles occlusion is. If they had a very large airway, which I doubt they would with an AOB, but let's say hypothetically, if we assessed their airway, we assessed their sleep, there was 0 issues. They had like a giant garden hose as an airway, and they had a giant maxilla, and they were class 2, well, heck yeah, then I will pull 2 upper bis. And as I close the spaces, because I have overjet, it'll actually close down the bite, and it's not impacting the airway. I'm assuming the myo said, okay, that would be the one situation where that might work for this situation. But that's the only scenario I can think outside of jaw surgery and or major myo involvement. But again, we haven't seen the whole face, so this is just a snapshot of something that we don't have the whole thing on. So I hope this was helpful. Thanks.